So I am very delighted to introduce Dr. Rebecca Hicks, who is an assistant clinical professor here at the David Geffen School of Medicine in UCLA. And today she is going to be talking to us about transitions through puberty. Please join me in welcoming Dr. Hicks.
Thank you for the introduction, Laura. I'm very happy to be here today. And so in my role as a pediatric endocrinologist, I found more and more over time that a lot of rare conditions, genetic syndromes, and neurodevelopmental conditions do have endocrine system involvement. However, since there's a lot of times other more pressing healthcare issues, sometimes we're not thought of initially. But I believe over time that we'll find out that there's endocrine involvement more so in rare genetic syndromes. I don't have any relevant disclosures. So I wanted to talk about first what happens normally in the body during puberty. So the hypothalamus is higher up in the brain, and that will stimulate the pituitary to produce LH and FSH. And then the pituitary will stimulate the gonads, which is either the ovaries in females or the testicles in males, to produce estrogen and testosterone. And then these are known as sex steroids. And then those will then feed back to the hypothalamus to help regulate GnRH production. And this is all a very sophisticated feedback mechanism to help regulate through different periods of life what those hormone levels should be. And the other part of puberty that a lot of people may not be as aware of is the adrenal glands, which sit on top of the kidneys. So there's a corticotropin-releasing hormone from the hypothalamus that will stimulate ACTH release from the pituitary gland. And the pituitary sits right behind the nose. So ACTH will then stimulate the adrenal glands to produce a multitude of hormones, but the major one for puberty is DHEA. And you may have also heard DHA sulfate, which is the major version of it that circulates in the bloodstream. And that is an adrenal sex steroid. Then the DHA will provide feedback for the ACTH production. So again, a very complex, sophisticated regulatory system. So we kind of think of an endocrine puberty as either a switch being off or on. So GnRH, when it's produced from the hypothalamus, if it's produced in a steady level, then that does not stimulate puberty. But once this switch goes on, which there's a lot of different factors involved, then that's what stimulates puberty to start, and we consider that central or true puberty. And that's when the pituitary gland will then have this pulsatile release of LH and FSH to stimulate the estrogen from the ovaries and the testosterone from the testicles. And this is going to be a rise that happens over time. And so this is, showing there's a lot of different changes throughout life. And even babies have what's called a mini puberty, which is the first underpinnings of having the reproductive axis mature. And then during the elementary school ages and toddler ages, and usually this kind of quiets down and there's low levels of these hormones. And then when this true central puberty starts, then over time you start seeing these levels rise in the LH to the FSH, testosterone in males and the estrogen in the females. And then with females, you can start seeing these, what happens with the menstrual cycles and ovulation, these rising and falling levels of the estrogen and LH and FSH. So there's a few different terms which you don't have to memorize, but for us as endocrinologists, it's very helpful to think of where the sources of hormones are coming from. So gonadarchy means that's when the gonads, either the ovaries or the testicles, start producing hormones. And in females, the ovaries, the main type of estrogen is called estradiol. So when females start having the first really tiny little breast buds, that's actually the very first start of puberty in most females. So it's not periods, that comes later. And then you'll see a lot of times some vaginal discharge, kind of that whitish, thinnish, clearish discharge. Sometimes you see it on the underwear. And then when the first menstrual cycle comes, we call that menarche. So that, most of the times, about 2 to 3 years after thelarchy or the initial breast budding, although there is some individual variation in that. For boys, testosterone is the main sex steroid that comes from the testicles, and the signs that you'll see from that is testicular enlargement, and that's a sign that they're making testosterone. So they start out smaller and then over time increase in size, and that coincides with how much testosterone they're producing. And then you'll start to see over time penile enlargement as well. And then voice deepening is actually a later sign of puberty. So if that's happening early, that means that then puberty is progressing fairly rapidly. And so those are the major ones, and then facial hair, also later. So again, we think of central puberty, the pituitary gland stimulating, versus peripheral puberty, which means it's not the pituitary gland. So the adrenal glands, when they start producing hormones, DHEA and DHA sulfate being the major one, that's called adrenarche. And the major signs you see is all the rest of the signs of puberty. So this would be the same in males and females. You start seeing pubic hair, we call that pubarche, underarm hair, acne, and an adult type of body odor. So there are stages of puberty. It doesn't happen overnight. And so as endocrinologists and pediatricians, primary care physicians, we'll look and see what stage the child is at and how quickly it's progressing. And so for females, looking at the breast development, that's our major sign of knowing what stage you're at in terms of the pituitary stimulating the breast development and the ovaries with the estrogen production. And then again, in the males, we look at the testicular volume and the penile enlargement. And then for both males and females, we also stage the pubic hair development, and that's the major sign for the adrenal glands. So we have seen over time that puberty is starting earlier, so the definition of what's normal has changed over time. At present, it's considered normal for a female to have some signs of puberty starting at 8 to 13 years old, and in males between 9 and 14 years old. So again, there's a very wide range. And then typically with females, the first sign you see is breast budding, and then later you'll see pubic hair growth. And then with females, the growth spurt, the peak of it is much earlier than with males. So they start puberty earlier, they have the growth spurt earlier, and then once they start having menstrual periods, then the clock is really ticking in terms of how much time they have left to grow. They've completed most of their growth by that point. On average, they might grow a couple more inches, although again, there's some individual variation. And then in males, again, the onset is later, and then you see the growth of the scrotum, the testes, and then later the change in voice, and then the lengthening of the penis, the growth of pubic hair, and then they have their growth spurt. So it's much later than with females. So the process usually takes about 5 to 7 years altogether. The earlier the puberty starts, the earlier the child will stop growing. So it can be very confusing sometimes for parents and even providers when the child is really tall. However, we're concerned if it's happening really early and very quickly, because that means, again, the clock starts ticking and the bones start maturing, and then you might be tall for your age, but if you stop growing at 4'11", that's your final height. So it all depends on when the growth phase closes. So I think of it as a tug of war between how fast you're growing and how much time you have. So the other key thing to keep in mind, so if puberty starts later, then someone might be a late bloomer, and so they may end up taller. However, if there is a health issue going on that's not addressed, that will affect the final height. So we define precocious puberty in females as starting at age under 8 years old, and in males under 9 years old. However, when we evaluate a child, we also take into consideration family history. Is this something that's normal for the family or not? How fast a child is growing, their bone age, which again is a marker of how fast their bones are maturing. And then we also look at how quickly is puberty progressing, the signs of it. So if the source is coming from the pituitary gland and stimulating the ovaries or the testicles, then we call that central precocious puberty. So one of the ways we define that is by having an LH level that is in the range of puberty. So it might be normal for an adult, but not normal for a child of that age, and we also look at it relative to the puberty sign staging that we're seeing. And peripheral precocious puberty is any non-pituitary source of early puberty. So that could be actually the gonads themselves. Sometimes they can start activating early for different reasons. Can be the adrenal glands, hypothyroidism. Sometimes it can be a hormone-producing mass as well. And then there are some pubertal variants. So not every child that has early signs of puberty needs to have treatment for it. It depends on, again, the whole situation. So sometimes they might have just early signs of breast development or pubic hair, but then it's really slowly progressive, and so sometimes one option is to wait and see what happens. So overall, central precocious puberty is about 4 to 10 times more common in girls in just the general population. With males, there's a higher risk of having a brain abnormality or underlying reason. With children with neurodevelopmental disorders, it's about over 20 times higher risk. So that's about 1 in 10,000. And again, that's taking into consideration that there are a lot more children that don't have the neurodevelopmental disorders, so looking at that population, it's a much higher risk than the general population. And then in children with autism spectrum disorder, whether or not there's a genetic reason that's identified, it's over 4 times the risk of children who don't have it. So as I mentioned, with females, you would see maybe breast development, vaginal discharge, bleeding, tall stature, but the bone age is advanced when it's really a significant central precocious puberty. And so the bone age, there was these very smart experts in the past that thought of doing an x-ray of the left-handed wrist instead of x-raying all the growth plates in the body. So pediatric radiologists will read this as well, and as endocrinologists, we have a standards that we look at, and we compare to see how does the child's hand and wrist x-ray match up to that standard and what was the closest age match. And that's what it tells us, the hormone exposure. And then in male, testicular enlargement, penile enlargement, may or may not have pubic hair, and then the tall stature with the advanced bone age. For the treatment, so what we're trying to do with treatment is turn that switch off. Yes? Oh, go back? Sure. No worries. So with treatment, we're trying to turn that switch off. So once it starts, that's what we have to do, and the only ways is to get that GnRH back at a steady state, so it's not stimulating the ovaries or the testicles. So there's a few different ways to do that, and this can vary on different countries as well. And then in the United States, we'll use a medication form of the GnRH, and so one is leuprolide acetate, and that's an intramuscular, so in the muscle injection every 1, 3, or 6 months. And then you can also do a triptorelin injection every 6 months, also in the muscle. And then another option is a hystrelin acetate implant. So it's kind of like similar idea to a birth control implant. It just goes right under the skin. And then it's FDA approved to replace that once a year. So if you don't treat this central precocious puberty, this can lead to psychological and behavioral issues and short stature because of the early growth plate closure. And there is one concern as well that children with developmental delays, this could make them more at risk potentially for sexual abuse if they're not treated for the central precocious puberty. And then that also leads to concern for early pregnancy. Yes? So one of the questions is, do any of these treatments affect epilepsy? That's actually a really good question. I'm going to talk a little bit more about seizures further on, and then I'll address it there, but thank you for the question. Yes?
Do you also find that, for our children, things, development is slower, right? Like, can the cycle of puberty be longer?
Mm-hmm.
Can it also potentially present in different ways?
So the question is whether or not, the children we're talking about, if sometimes puberty might happen more slowly or present in different ways. And yes, so I always think of with hormones as puberty as the rogue one. With some, there's even some conditions where we know the pituitary gland is involved, and you might have deficiencies of other hormones, but puberty might be early, or it might be delayed, and so it's not always something that we can predict. So what I educate families is that I know that there's a higher risk of puberty not developing the way we expect, but it could still happen the way we expect, and so if I'm following them, I just monitor for that to see and what might need to be addressed health-wise. So typically with girls, and again, this is like the general treatment strategy, you would treat till somewhere to 10 to 12 years of age, and then boys around 11 to 13 years of age. So but you want to really take into consideration, it's a mutual discussion with the families regarding growth, the predicted adult height, their readiness to resume puberty as well. So we will follow them, on treatment and continue to discuss how they're progressing, how they're responding to it, and then at what point would be the most appropriate time to stop the treatment, and then the next steps after that. And one of the major concerns is that if you continue the treatment for too long, that can potentially increase the risk of fracture. So that's one of the reasons that we cannot just suppress forever. And this is kind of a busy slide, but I think it's kind of a helpful example of what happens. So this is a child where they had a really quick growth spurt, and then the weight was going up with it as well. But the bone age is the triangle. So if you look at, maybe for their age they were tall, like 90th percentile, but for the bone age, it's a little hard to read, but I think this is about maybe 10th percentile. So the idea is, for that bone age being older, this is the height percentile you would expect them to end up as an adult. And then the other thing to keep in mind is that is one snapshot in time. So that doesn't mean for sure that's what's going to happen. It's very complicated growth and puberty, and nobody knows with exact certainty exactly where a child is going to end up for their final height. But we kind of take that into consideration, and then if the bone age continues maturing faster, then that final adult height can be even shorter. And then if you put them on treatment, then it slows it down and helps them hopefully reach closer to where they're supposed to end up. So that's one of the treatments.
I'm looking at this. My daughter also happens to have Down syndrome, and they definitely look at all these kinds of charts and things, and they recommend like a subclinical support for thyroid to help with this kind of thing. Does that affect puberty, its onset and duration as well?
If so the question was for children with Down syndrome, whether or not having a thyroid disorder might affect puberty. Absolutely. And thyroid, so if they're hypothyroid, low thyroid levels, that can cause puberty to start late or be slowly progressive. However, once in a while, if it's a really severe hypothyroidism, the body actually gets really confused and thinks it's hormones for puberty, because some of these hormones look similar to each other, and it can cause it to actually progress rapidly. So it definitely, with thyroid conditions, you have to monitor closely growth and pubertal development, and then we monitor the thyroid levels closely as well to make sure they're at the goal. So thank you for the question. So peripheral precocious puberty, switching to that. So again, this is not involving the pituitary gland. And so the features that you'll see are going to vary depending on the cause that starts it. So with females, again, it can be different signs that you see. You may or may not see early breast development. You may or may not see vaginal discharge or bleeding, possibly pubic hair. And then, but you will typically see tall stature with advanced bone age too, if it's a significant cause. And then males may or may not see the early testicular enlargement, penile enlargement, and pubic hair, but the tall stature with advanced bone age and any signs of puberty, we would be concerned. And then the treatment is to treat the underlying disorder in this case. What I will say is sometimes it starts out as a peripheral cause, and that just disrupts that switch and turns it on for the central precocious puberty. So we do sometimes see a mixed picture as well, and in that case we have to just address the whole picture. But once you turn that switch on for central precocious puberty, even if there's a peripheral component, you still have to address the central with that treatment. And then the variants are non-progressive, self-limited, tend to have a normal bone age and height, and the bone age can be a range of what's normal. So the idea is it significantly out of what you expect or not? And you can have, sometimes girls get a little bit of breast development, but then it just starts and you don't see anything for a while. But we also tend to follow that too, to make sure that it doesn't progress. And as I mentioned before, that kids have early mini puberty. Sometimes they get just a little bit of an exaggerated one, or it just is prolonged a little bit longer. So that's one of the options that can happen. And sometimes you just see the breast budding on one side instead of two. But up to 10% will get central precocious puberty, which is one of the reasons that we want to monitor it. So with the pubertal variants, there can be different signs you see with that one as well. And you want to just make sure you're not missing something significant that needs to be treated, and the height and the bone age and how rapidly you're seeing changes are the clues. And typically you'll see that elevated DHA sulfate level. And then even if overall it doesn't look like there's anything concerning with their health that's going on, it's important to keep in mind that about 20% of the girls that have early signs of adrenal hormone production are at risk for developing polycystic ovary syndrome, PCOS. That's a whole nother topic, but I will just mention that some of the signs you see is irregular periods, you can have cysts in the ovaries, facial hair, really bad acne, so that's definitely something you don't want to miss. And there can be higher risk of like type 2 diabetes and other health issues. And then if there's isolated early vaginal bleeding but no other signs of puberty for girls, then you want to make sure you're not missing abuse, a foreign body, or a tumor. So that should be evaluated. And this is rare. So on the opposite side is a delayed puberty. And so that would be if a girl does not have any signs of puberty by age 13 and in boys by age 14. And then amenorrhea is if a girl either has not had any periods altogether within the expected time frame. So because of the changing definitions of when puberty starts, the most recent literature will say if a female does not have any periods by age 15, no matter when the sign started, that would be considered primary amenorrhea. Or from the time that she starts having breast buds, the tiny ones, by 3 years after that. And then secondary would be if she had periods and then stopped. So most recent definition of that is if she goes at least 3 months without a menstrual period. So depending on what literature you read, you might see different definitions, but the most recent studies in Haynes going through the United States show that it's pretty rare to go that long without one, and then you want to consider evaluation. So causes, it could be an issue with the hypothalamus higher up, and with children who have difficulty gaining weight, sometimes that's one of the reasons why you see puberty doesn't start when it's supposed to, or it starts and then it just doesn't progress within the sequence of timing that you would expect. There can be also, we see also like excessive exercise, inflammatory state, frequent illnesses, so it's just the body's kind of being shut down from those other reasons. It doesn't mean that there's something else going on necessarily with the brain. And the pituitary gland, you can have other hormone deficiencies as well that need replacement. And then you can also have a growth or a tumor in the pituitary gland that's producing too much prolactin. And that's a hormone for lactation, for milk production. So if you have too much of that, it's just like a woman who's pregnant or breastfeeding, then the ovaries say, oh, well, I don't really need to make this estrogen. And then that can also be medications, and sometimes the medications for the psychiatric medications like for seizures and also for behavior, and then sometimes surgery can affect that as well if there's other processes in the brain. Also, the gonads themselves can stop working, and that can happen with genetic conditions or sometimes autoimmune conditions. And then in that case, sometimes families, we have this discussion whether or not really they should go on any hormones at all. But the problem with not putting them on a hormone replacement is that that can affect the bone health and overall health. So it is actually recommended to do hormone replacement in those cases. With girls, it's estradiol initially, and then eventually we add on progesterone. And then with boys, testosterone, and that's also important for muscle strength. And I mentioned that PCOS. There is an increased risk in girls with seizure disorders treated with valproic acid. And then the signs and symptoms I mentioned as well. So, and then the question about whether or not the treatment for the central precocious puberty, related to seizure disorders, puberty itself can actually unmask someone's underlying tendency towards seizures. So those medications, because it's similar to the GnRH that the hypothalamus produces, you can sometimes see seizures on the treatment. However, what you would typically see is if someone had breakthrough seizures because of signs of puberty, sometimes doing the treatment actually slows that down and improves it. But if someone before didn't actually have seizures but might be at risk for it, sometimes when you put them on treatment, they'll have it. But I think I've had one case so far. So it has been described, but it's not a common side effect.
Like if you, I guess at what point do you engage an endocrinologist? Like is that when you see certain signs, or you're like concerned that there could be a delayed puberty? Like, is there like a regular check that you recommend in terms of looking at the hormone levels?
So the question was, when do you engage an endocrinologist? And I actually do have a slide. I kind of put a summary one at the end. But yeah, anything that's kind of like significantly outside of the abnormal. And it's always good if, with primary care providers or geneticists to kind of, get that initial evaluation and discussion and having a low threshold for referring. And then pregnancy is something you definitely don't want to miss as a cause. And also obstruction to menstrual blood flow. So a girl might not have a period because the blood is there, but it can't get out. So that's also something really important you don't want to miss. It can be very painful too. So and then circling back to, we touched upon this, but puberty and neuropsychological considerations. So puberty, we often think of as the brain on fire. Even when it happens normally, there's a lot of changes rapidly during that time, and these really rapidly changing hormone levels that have not been experienced before by the child. So you see physical changes, and the child is going to then be treated differently by peers and adults than they had before. And then there's multiple impacted areas of brain development, social awareness, and peer relationships during puberty. So also wanted to talk about, as I mentioned, I'm asking the underlying risk for the seizure disorder, and for girls sometimes you'll see catamenial seizures, which means that it's happening around the time of the periods, or sometimes it happens during the surge of ovulation as well. So you just see specifically it occurring related to certain times of the menstrual cycle. And it's thought that it's due to a surge in estradiol during the time of ovulation, because estradiol will excite the neurons, whereas a few days prior to menstrual start, then you get a drop in progesterone, and that is the one that actually inhibits the neurons, but because of that drop, then that can also raise the risk of having seizures during that time. And the way to try to figure this out is to keep a seizure diary. And it turns out if you try to do just hormonal manipulation, most of the time doing that doesn't necessarily help in terms of like if they're already having menstrual cycles. Although if it's central precocious puberty and they're having periods early, then sometimes putting them on that treatment with the suppression can help. So ways to kind of work with this would be with the seizure medications themselves. The girls can take a low-dose benzodiazepine, or they can increase their usual anti-seizure medications at the time of these breakthroughs, and that would be something to discuss with the neurologist. And then if that's not effective enough, you could consider instead doing prometrium, which is a type of progesterone, for 200 milligrams 3 times a day, starting 14 days prior to the period, and then you would just taper off over the next couple of days after the period starts. There has been a possible association between elevated DHA levels when there's early signs of adrenal puberty or premature adrenarche and anxiety, but unfortunately there isn't really a specific treatment that we have currently to address that. And then puberty hormones can also mask underlying risk for psychiatric disorders like depression and anxiety, and that's seen more commonly with girls, and in boys you see more risk-taking behaviors as well. And one thing to keep in mind is that if there's limitations with verbal expression, then it's really difficult when these children are experiencing all these feelings and emotions, they don't know why. So even someone who doesn't have those verbal limitations, sometimes you don't know why, you just all of a sudden feel so upset, so angry, and it just kind of, just comes on like that. So when you then can't express it effectively, then it makes it much more difficult, and then you see more of these tantrums and outbursts and aggression. So I did want to also discuss about menstrual management with girls who have disabilities and neurodevelopmental conditions. The most recent guidelines on this are from 2016. There's actually pretty limited literature on this subject, and it's more of committee opinion with the American Academy of Pediatrics and the American College of Obstetrics and Gynecology. But the consensus is to start having this discussion before the menstrual periods start. And this can be a discussion that starts with the primary care physician, and then maybe just, initially with the geneticist, and if there's a psychologist, psychiatrist involved, starting that discussion, and then if needed can then escalate to a pediatric endocrinologist, or again, I'll review later on the potential referrals. And then you can discuss concerns as well about sexual education and expression. And so sometimes it's assumed that a child who's delayed may not have sexual education or need a sexual education and may not express it, but that's not necessarily the case, so you can't make that assumption. And then it's also really important to guide the families to help prevent abuse and what strategies for that. And then in terms of menstrual cycle manipulation or management, it is also really important to take the child's needs into consideration so that you're really addressing what they need in terms of like mobility and if the periods are painful or really heavy. And then it's also important to have a discussion about the benefits and limitations of the different methods. So reasons to consider doing the menstrual management would be for hygiene, the menstrual cramps being very painful, catamenial epilepsy, if periods are really heavy and irregular, and contraception. But it's also important to realize that this is not going to help protect against sexual abuse or sexually transmitted infections. And it's also not recommended prior to the start of the first menstrual period for females. The reason is because you want to make sure that the genital tract is formed. Again, they can have an obstruction to the menstrual flow. So this is a way of just being able to tell that you don't have that issue. And then you can also monitor to see how she is being able to tolerate the menstrual periods and what the cycles look like. And again, they're not going to be initially totally regular, but they should be at least reasonable. And there are definitions of what you consider to be normal in the first year or 2 years or 3 years. I've heard sometimes, oh, it's totally normal for it to be totally irregular. That's actually not true, but that's where sometimes you need someone with a higher level expertise and training to be able to tell if that is what you expect or not. And I mentioned as well that precocious puberty, you can't treat forever, but maybe up to 12. That's a little bit debatable what the cutoff is, and then after that, monitor and then decide. So you can counsel the girls in a developmentally appropriate manner to help address their concerns and symptoms. So it is really difficult to stop menstrual cycles altogether. There is actually high rates of unpredictable breakthrough bleeding with continuous suppression. And so the definition can be a little bit confusing too. Extended means that you're just going longer than you normally would. So for example, having a period every 3 months or 4 months versus continuous means you're trying to keep them on the hormones to suppress puberty year-round. But that is difficult to really not have any breakthrough bleeding. So then you want to have that discussion whether you want to aim to do complete suppression, not have any breakthrough bleeding, hopefully, or you want to just aim to have scheduled menstrual periods several times a year, which is a little more predictable. And if the first approach that you try doesn't work, just recognize that it can take up to 4 times, and then it's average about 1.5 methods before you reach the results that are satisfactory. So there's a lot of different ways to do this. In the handout, I put much more details from these resources, but this at least gives you a summary table. And overall, usually the birth control pill or combined contraceptive pill is the one that's used the most, and you can either do it so you have, again, a period every few months or just year-round trying to suppress. These can interact sometimes with some of the anti-seizure medications, so that's important to have that discussion with the neurologist and then whoever is managing the menstrual periods. And then also these hormones that have estrogen in it can put the child at increased risk for blood clots. So if there's mobility issues, then that's also something to keep in mind. Tends to be higher risk still in adults, but theoretically at least it could be potentially. So if they have any reason like family history of blood clots, then you want to be more careful. And the vaginal ring is another option. So it goes through the vagina and sits below the cervix. And it's actually labeled to change out once a week, but there's enough medication that you can change it once a month. But the question is always, can the girl put it in herself? Does she need help? And that is a privacy concern as well. And then you can also do the patch, which is waterproof, which is really nice. You change it out once a week. But you can try to then continue on the patch instead of doing a week off every month, so that way there's less menstrual periods. And then if there's a reason that you can't use the estrogen, you can also do a progesterone-only treatment, which can be the pill. And the pill you have to really take very consistently every day around the same time. There's a little more risk of breakthrough bleeding. And it can interact with other medications, antibiotics as well. So one thing to keep in mind is whether one of the goals is contraception or is it mostly to help regulate the periods or suppress them. You can also do Depo Provera, which is an injection, and you can do that every 3 months. With the catamenial epilepsy, some people try doing it closer together, like every 10 weeks instead. And it does have a black box warning that it can affect bone density. So it's right now, the recommendation is to limit the use to 2 years. However, if you have a child where there isn't really a better option, then you could consider going a little bit longer, but you just want to have that discussion about it. And then the implant lasts 3 years, so that is another option, but there is more breakthrough bleeding. So if the child has periods, it's going to be hopefully less painful and less bleeding, but it's just less predictable. And then another option is the IUD. So this is the implant. The IUD then goes up through the vagina, through the cervix, and then sits inside the uterus. It's actually really small, and the issue is with that one is the patient might need some anesthesia to insert it and remove it. So, and then it's more difficult to insert if they've never been pregnant, and then they can have a lot of painful cramping with that too. So, and then the other options that are sometimes discussed or asked about is doing endometrial ablation, where you go and destroy the endometrium inside the uterus, which is the lining. But it turns out it doesn't work that effectively, and that's a surgical procedure, and sometimes there needs to be repeat procedures. And then a hysterectomy is even more significant, where you remove the uterus altogether. And so there are legal and ethical issues, and the different states have their own laws, and sometimes an ethics board has to be involved in making these decisions as well. So the last thing I wanted to cover was the red flags. So with girls, if they have onset of signs of puberty under 8 years old, or boys under 9, or puberty is happening very quickly, faster than you expect, and also sometimes what happens is you don't recognize when it really first starts, and you start seeing it when it's becoming more significant. So if you're seeing it happen really quickly, or if you don't see any signs of puberty by 13 in girls or 14 in boys, and then also no periods by 15 in girls, and then also not by 3 years after the start of breast development. And then I also included in here the guidelines for when you would refer based on the menstrual periods. So if they're really close together or they're really far apart, and that definition varies a little bit depending on how soon they started. But the way I always remember it is you're going from the first day one period starts to the first day of the next one. And if it's under 3 weeks or over 3 months apart, then that should be looked into and having discussion. And in this case, it might depend on where you're at as to who would be the right specialist. Could be a pediatric endocrinologist, adolescent medicine, or gynecologist, and also depending on the age of the girl. If the periods are really heavy, lasting more than 7 days, or soaking more than 1 pad or tampon every 1 to 2 hours, then also. And then if there's increased behavior, aggression, or concerns for depression and anxiety, I think it would be good to first start with the team that already knows the patient, and then see if you need to go to other appropriate specialists. And so sometimes some options are like a psychologist or a psychiatrist, a neurodevelopmental pediatrician, a neurologist in case there's seizures or other reasons causing this, and then considering also referrals to pediatric endocrinology, adolescent medicine, or gynecology if there is suspected to be a hormonal imbalance or for assistance with menstrual management. And then lastly, with catamenial epilepsy or suspected, I would recommend seeing the neurologist first to have that discussion, and then consideration of referrals to pediatric endocrinology, adolescent medicine, or gynecology. All right, thank you so much for your attention. Are there any other questions?
So, for the girls, you talked about sort of like a lot of the changes are happening around their cycles. Do you see any cyclical changes for boys or certain times when this is impacting them more?
Yeah, the question is, for girls, you tend to see these changes more in there's menstrual cycles. For boys, do you see any cyclical nature? So for the girls, that's true once they start having menstrual periods. However, puberty itself, as I was showing earlier too, that it doesn't all happen overnight, and the hormone levels change over time. So you do see when the children are having these growth spurts and they're having these surges in their hormone levels, especially relative to what they experienced before, you do see sometimes these changes in behavior. And even if they need treatment, then sometimes just those hormonal types of treatment sometimes can then unmask that, or even thyroid disorders too, if they're not used to certain certain levels of thyroid hormones and they're really significantly underactive or overactive, and then you try to introduce treatment, sometimes you'll see changes there too. For central precocious puberty, when you initially start treatment, I should mention that first month is actually going to stimulate puberty, and then after that should shut it down. So you will see sometimes an increase in that initially, but if you can kind of hang on with it, then over time, as you keep it suppressed and stay on the schedule, then usually you see it really calm down for a while. So, and then we had another question back here somewhere. Oh, yes.
With my kiddo, she starting puberty but is not menstruating yet, but we have seen a pretty severe uptick in seizures and neurological episodes. So as far as like, there's not much of a diary that we could do as far as menstruation goes. Is there the same kind of correlation with the onset of puberty and spikes with seizures, or should this be something considered separately?
I want to make sure I understand. So you're saying with your daughter, she started having increased seizures after the start of menstrual cycles?
No
puberty
menstruation
is all.
yet,
Oh, okay, sorry, no menstruation. Okay, with the start of puberty, and so you're saying can it increase just because of that, even without?
Without the menstruation, would that be the same type of seizures that you would see that go along with the diaries and things where you can see with menstruation and the ovulation how they have causations there? Is it the same hormones that would be introduced earlier and start seizures right around the onset of puberty?
Right. Okay. So so even without the menstrual cycles, can you see these increased seizures and right? Yes. So you can because of those changes in the hormone levels, but then it tends to be less predictable in that case of when it might occur, and so it's difficult to say what the trigger is specifically in that case. And so the question is a normal puberty or is this central precocious puberty? Because in that case, you could treat puberty to suppress it. But if it's normal puberty and it just happens to unmask someone's underlying seizure disorder, then you have to treat the seizure disorder itself. Just like there's other triggers for seizure, like illnesses, hypoglycemia, low glucose levels. If there's other triggers for the seizures as well, then if you can address those, then great. But sometimes it just means having to adjust the medications with the neurologist. With the menstrual cycles, if you can identify when it's happening, then you can address it in that regard. But if it's not predictable, then it's just a matter of first seeing is there something going on underlying that you can address, or you just have to adjust the seizure management. Are there any other? Oh yes, in the back.
So we recently started Depo in January, and after the first shot, she actually still got a period, but she had a seizure before that period. We started it because she was having like decreased motility and insomnia right before the periods. She still is having periods that are greater than 7 days, but not heavy. And I'm just trying to figure out, should we stay on the train and see if it improves, or is there something else we should, because maybe it's not right for her, or how do you know if it's helping her?
That's a great question. So she's had one dose of the Depo?
Well, she's had, so it's July now, we started in January.
January,
So
okay.
about 7 months.
Okay. So the question is her daughter has had 7 months of treatment so far with the Depo, but still having periods. And so the question is whether or not to try switching to something else. It is helping with the mobility.
It is helping with the insomnia. We also know that as soon as we started the Depo, she had moments of crying every night that we now are treating with gabapentin. I think things are balancing out. I guess, could this birth control, it doesn't necessarily wipe out all of your problems.
Yes. So it's not a magical wand. But the ongoing treatment with the Depo, then you actually start to see more improvement over time.
Okay.
So initially, again, anytime you do any hormonal manipulation, there's always an adjustment period for your body, and so then you'll see some of those symptoms and breakthrough bleeding. But eventually, if you stay on it, it actually has one of the higher rates of being able to suppress it. And some girls might have, a little bit of breakthrough bleeding here and there. And actually, the handout has a little more detail about that. But yeah, ongoing treatment, then it should be more effective. So I probably would stick with it for now before deciding that it wasn't effective. And then if not, then you can discuss other ways of helping.
Thank you.
Yeah. Okay, so you said the first signs you saw were at 4 years old, and then the period was at what age?
You started your period 4 months ago.
Okay, and she's 10 now?
She'll be 10.
Yeah, so in that case, most likely she's completed most of her growth, and usually after the period, most girls will grow a little bit more after that, maybe an inch or two. I've seen some kind of level off and not really grow after that, and there's others that will grow a little bit more, and sometimes that's just the family genetic programming. The most definitive way is to check a bone age x-ray. The question would just be whether or not that would change the treatment. So. Any other questions? Well, thank you for the great questions and your attention.